So with that, I'll turn it over to Renuka and again ask her to maybe speak to the objectives of the program and BD's motivation in terms of launching this public-private partnership with both USAID and the government of India.
Thank you, Brenda. And again, I never get tired hearing Amy talk about TB. Always fascinating. But it's the afternoon session, the last session. And before we go into the actual topic here, since Brenda, when you introduced me, you kind of had a smile on your face and said, my longtime friend, Renuka, I thought we would talk about our friendship to start with, because we both first met in Uganda at a WHO meeting in task shifting. That's the first time we met each other years ago. We don't want to go back how long ago. and then we said, okay, both have traveled from New York, taken this long journey. It was a great destination to talk of task shifting, which is still happening today, I assume. And then we said we're back on the same flight, and both of us had a 7-hour layover in Amsterdam. And we said 7 hours, and so our journey was like some 30 plus hours in good old times, I guess. There were no better flight connections. And we said, what are we going to do? We're going to die. And all through, we were cribbing about how many hours. That was the only common topic we were talking about. And we landed in Amsterdam, and we said, okay, let's sit down, wait, I guess. And then suddenly we heard an announcement, last call for passengers, Brenda and Renuka. And we did not know how the 7 hours passed by. We were almost going to miss that flight, and we were running past. So just to say, that's where our long friendship brewed. And so it's great to be on this panel, and thank you for the invitation.
And Renuka did all the talking in Amsterdam. I just want to clarify.
You can check the time now. But I think just to build off Amy's commentary here, so what did we do from addressing the problem? Actually, her last slide on the private sector engagement framework is interesting, because the last block of that chart was, can USAID play a role in overcoming some of these constraints? And that's interesting, because that's the mindset that USAID, I guess, had when they came into this dialogue. And the constraints were, as Amy said, WHO changed their guidelines so often that countries were confused, and there were instruments that were dust collectors. That's one. But the second slide that she showed, people who need to get DST testing were not getting tested. And that was another big problem, contributing to a bigger challenge. And BD, and I lead global health at BD, as Brenda's already said that, but I come with some experience on public-private partnerships. I see John here in the audience. I have to say our long-standing 12th-year collaboration with the US government, PEPFAR, and CDC on a program called Labs for Life, primarily around strengthening systems for HIV. And so this working on TB seemed like a natural extension, and we were glad to work with a different agency within the US government. We've been working with you and CDC. So it was great, because USAID was the only other agency other than Global Fund that had TB very prominently on its agenda for many years now. So when we met, and so I'll just also go back. So the public-private partnerships that we have typically fall into different categories. One can be pure product donation, and that's obviously philanthropy. That's one area. Another area is just pure advocacy, and that's where you see us engaging with Global Fund or with Stop TB or other health agencies. The third one could be purely CSR, strengthening health systems. There's no quid pro quo. Doing this doesn't get you an additional sale, as Maria Rosa was talking about in her commentary, and that's purely health systems. And the fourth one is a shared value approach, where you go upfront saying you're doing this, and there's return on investment for both parties. You're probably making some money, but you're also solving a problem. So that's how we typically look at the landscape of partnerships. And so our program and partnership with PEPFAR was purely on the health system strengthening. It had no other goal, and it continues to be very focused on developing the ecosystem and nothing to do with the BD product. But our partnership with USAID was all about the BD product and the part that it has to play in actually reversing the trends that exist today. So when I first met Amy, and I don't know if you want to impromptu chime in, you could.
Sure.
So Amy was like, why is this person not talking about her product? Because my hat was, well, I'm going to work with them like I work with PEPFAR. So I was like, this is all about health systems. What can we do? And Amy was like visibly irritated. You may want to add why you were irritated.
Well, it wasn't visibly irritated, but we were very polite at that stage because we didn't really know each other very well. So it was a little frustrating. We are all about systems. We absolutely know that one of the biggest problems is moving specimens, right? That's a huge issue. The reporting, the recording, getting results back, those are huge issues. But we have a whole host of partners that are working on that. We have projects dedicated to doing that. What we don't have is BD, who is coming and saying that we're interested to actually have these instruments work. It was hysterical. How many times did we talk, and she never brought the midget up, and I just didn't know what to do. I said, and one day I think I just said, are you not making it anymore? Are you getting out of this market? Because if you are, then we have to really talk about what the purpose of this partnership is. But we knew that we had an exact need. We're very interested to talk about those other things. And in India, when we get to that, BD is absolutely being instrumental in specimen transport collection. And we think that there is a responsibility, for the private sector or the company, however you want to say, is to think about, how these tests and how these products are used in country, not just dropping it in. But anyway, so that's, but we've realized how we're on the same page, I think.
So Renuka, can I just interrupt here? So I'm curious to know, what was your hesitancy? What was that based in to mention the BD product?
Really good question, Brenda. And none of this is rehearsed, so it's great. We're just going to have a true fireside chat. So it dates back to years ago when we first signed the MOU with CDC and PEPFAR in 2007. And it is probably the first MOU between a public sector and a private sector to strengthen labs. I don't think there was such a significant MOU in place prior to that. It took us a year almost from the time we wrote the concept note, gave it all kinds of acronyms till we landed with this name, Labs for Life, eventually. But it took us a year long to make sure that there was a common understanding of goals, a clear articulation and understanding of each other's strengths and what can be done. But a big issue of that was conflict of interest. It was, well, if your company has products that may be relevant to HIV, how do we ensure that we're engaging in an MOU with you? Because we need you to help us accredit labs to perform well, but how do we ensure that we're not being viewed as someone who's doing this to give you a sale? So this conflict of interest issue is real. Both sides, by the way, our lawyers were paranoid, as was the US government's lawyers. So it took a lot to come in and say, okay, doing this by no means gives you an advantage. So it was a very different kind of a collaboration that was focusing on purely building the ecosystem, and there was no other benefit coming out of this. That was my mindset, and I assume that that's true for all US government agencies. And so even as Amy was trying to steer me towards product discussion, I kept going back to the ecosystem, trying to convince her that we can work with you on the system. And she used the word midget, and just no pun intended, midget is the name of our product. It's a bacterial growth indicator tube, the platform that is used for the DST testing. And it's been around for a while, but obviously we've had our ups and downs with the WHO movement. And so this was like music to my ears. Wait a minute, she's actually talking to me about an area where we have so much competency, so many experts. People were just, we were not killing midget, but I was thinking midget's probably dead, because every conference that you went to in the TB Union was talking about the next new bling and new shiny penny. And so we were not sure where we fit in that equation. And Amy came in and she spoke about the issue with such elegance and said, we at USAID want to solve this problem, and we can solve this problem with your product. And also, by the way, you can work on the ecosystem. I have to say, at that point, we were also building off a very successful experience that we had in Indonesia with TB. I see Kendra in the audience here from USAID, and I have to acknowledge her presence, because when we visited USAID in Indonesia, this conversation came up, and we had already started working in Indonesia on helping about 9 labs develop quality systems, move towards accreditation, and lo and behold, we actually ended up placing our system. So that I would call this as a shared value category of partnerships. So if you say the different types of partnerships. And so we had that, but I wasn't sure that Amy was coming to me with that mindset. And so when she actually said, are you not making this product, something to that extent, then it dawned on me that, my goodness, this could be sweet music for the businesses as well as for us, because together then we are able to solve. So the other thing is, you said with companies not interested in a comment, and it's really one of those situations where I want to say the companies can't solve complex global health issues alone. And that was the challenge we were facing. Why are we interested now? It's because we know that we're working with a very reliable partner who's paved the way to introduce us to the government of India. Nishant is not here today, but that's another. So what happens at a global level is this dialogue, and how does it go locally, and what are the local challenges is yet another aspect. But today we can sit around to say, wow, how nice, let's reflect on the program and the success. And now we're talking about how do you scale this from one country, not that India is any small country, but how do you scale this now to other high burden countries where we can have an impact. So that's kind of our story.
I wanted to comment about the conflict of interest issue. So we as other agencies do have concern about that conflict as well. In the TB space, it's a little different because we don't have a lot of competition. We don't have a lot of products. And to be quite honest, the BD midget system is the only liquid culture system available. We have like 1 LPA or 2 companies. I mean, we have very few options. I'm not saying it's a bad option. I don't want us to think we're doing it that way. But it was easy for us to decide to have this partnership because it was technology that was already in country. There wasn't an obvious competitor that we would have to explain or to really justify why we were working with BD in that space. So I do believe that a lot of the stars did align correctly for this partnership to happen.
And it's interesting. So yes, you can say we're the only game in town for that liquid test culture. However, even so, proactively several years ago, even during the Expand TB, Challenge TB, prior to those, all the projects that the TB world knows, BD proactively reached out to the global agencies to say, hey, we want to provide an access pricing. We know that you need these tests. And it wasn't because anyone approached us to say, drop your price. But we knew that to be relevant in some of these low middle income countries, particularly to drive access, that you had to have affordability at its heart, good enough so that we can continue to be in business and good enough so that you can drive access. So there were a lot of things that we were proactively doing, but at some point in time, the progress was impeded by systems issues, policy issues that we couldn't tackle on our own anymore. So where are we with strides today, right? So having gone into India, training, 35 labs, lab technicians, we've discovered that it's not just about the training or the competency to understand the systems, which is a big challenge. There are very smart microbiologists in these places, but of course training, reinforcing education, updating their knowledge is one part. And the other part that we found was, I think Amy was talking about this earlier, just the ecosystem challenges in terms of specimen transportation. India has 13,000 microscopy centers and 55 labs that have our instruments. So you're talking about thousands that need to reach some of these labs. How do you manage that? How do you have information and data that can show where in the process is the sample either lost or sample not happening? Can you click at a computer in your office to understand what's happening at the microscopy center and the lab? Now, the government of India has some very strong programs. They have a system locally developed called Nikshay, but Nikshay does not gather this piece of DST information. So here we are working with the government in trying to build an ecosystem, which is purely beyond our expertise or product, but we're working with an agency, with the Tata Consultancy Services, who has the capability of bringing that technology to bear. So we are working with them to get this technology. So the partnership has morphed into many ways in many different areas.